For this video, the focus will be on teratogenic agents, really focusing on drugs that are going to fall in this category. So we won't talk about any other teratogens in this video. And teratogenic essentially refers to an agent's ability to interfere with normal embryologic development and may lead to a wide range of consequences depending upon the agent's mechanism by which it causes teratogenicity and the fetal cell population affected. So for this week's video, we will go over how retinoids are thought to elicit their teratogenic effects. We'll go over other common mechanisms by which drugs lead to teratogenicity, and then we'll discuss a mnemonic for remembering the big teratogen culprits, and then we'll just briefly introduce several measures that are in place to help ensure safe and appropriate use of teratogens in pregnant patients or patients that are of childbearing age. So first we'll start off our discussion with retinoids like tretinoin, which comes up in this IQ case, as well as other agents like acitretin and isotretinoin, which will be important later on in this video. And these agents will all mimic the actions of vitamin A and other retinoids that are lipophilic, so they can enter a variety of different cell types where it can bind the retinoic acid receptor or the RAR receptor, which is a nuclear receptor that will heterodimerize with the retinoid X receptor or the RXR. And then this heterodimer of RAR and RXR can then translocate to the nucleus to bind retinoic acid response elements or RAREs, and these will then alter gene expression. In keratinocytes and follicular epithelial cells, this can lead to beneficial effects for the treatment of acne and psoriasis. However, this can also cross the placenta because remember, these are very lipophilic compounds. And once across the placenta in pregnant patients, this can alter the expression of genes essential for development, leading to neural crest-related developmental defects. So moving to our next slide, and neural crest cell disruption is one of the primary general mechanisms by which drugs can elicit teratogenic effects. Other general mechanisms include folate metabolism, interference, endocrine disruption, as well as oxidative stress, and then the last one is vascular disruption. So as you come across new drugs each block, think about their primary mechanisms of action to treat whatever disease they're indicated for, and if they have any off-target effects, and think about if they are likely to fall into any of these categories. That will help give you a hint about if the agent is likely going to be teratogenic or not. So there are also a number of specific enzyme or receptor mediated teratogenic mechanisms that aren't going to fall into these categories that you may come across, like the angiotensin converting enzyme inhibitors or the ACE inhibitors are common blood pressure medications that lead to teratogenic effects, as well as nonsteroidal anti-inflammatory drugs or NSAIDs like ibuprofen that inhibit COX enzymes can also lead to teratogenic effects as well. So now the mnemonic I have always used to remember the big drug culprits of teratogenicity is Teratoa, which stands for thalidomide, epileptic medications, like valproic acid, for instance. The next one is going to be retinoids, followed by our ACE inhibitors and our ARBs, or our angiotensin II receptor blockers, and these both are going to hit in a similar pathway. The next one is our third element, aka lithium, followed by our oral contraceptives and hormones. Next is warfarin. And then the last one is going to be alcohol. So you do not need to memorize this for this particular IQ case, but this will be a really helpful mnemonic for board studying and in clinical practice. So now that we have the teratogenic agents, what sort of measures are in place to help us balance the risk versus benefit of administering an agent with documented or potential fetal risk to a pregnant patient or a patient of childbearing age, and importantly, the fetus? So let's move on to the next slide. The first measure we will discuss are the FDA pregnancy risk information, which has to be included in every package insert for every medication. And this replaced the previously used FDA pregnancy risk letter categories in 2015. So you may still hear these referenced, even though the risk information is the most updated version. So the letter categories, just so you know, included A, B, C, and D, and then X ratings. And with A being no documented fetal risk despite well-controlled trials, all the way to X, which means the agent demonstrated clear fetal risk and the risk outweighs the benefits of administering this drug, essentially meaning that this agent is contraindicated in pregnancy. So this letter system was replaced by the new system because there were complaints that the letter system could be misleading and did not provide sufficient information about the studies for the clinician and patient to make a well-informed decision. So this was replaced with the pregnancy risk information on all drug labeling and included narrative sections, pregnancy exposure risk, it also included a risk summary, clinical considerations, and data. So everything is laid out to allow for better patient-specific counseling and informed decision-making for pregnant patients seeking therapy. A second measure in place is a risk evaluation and mitigation strategy, or a REMS program. For some extremely high-risk teratogenic agents. Now, I do want to point out that REMS programs are not specific for teratogenic agents, and can be found for a multitude of agents requiring added safety measures. But we will just focus on the teratogens here. And a REMS includes specific education or activities that must be carried out by one or more individuals involved in the treatment with the agent that requires the REMS. So this is commonly the prescriber, the pharmacist, the patient, and the manufacturer. So those prescribing, dispensing, and taking the medication all must be informed about these risks. So when talking about teratogenic medications, the REMS program may require different elements to assure safe use, such as a signed patient-prescriber agreement for a drug that may cause birth defects, a negative pregnancy test each month prior to the medication refill, or the use of 2 forms of effective contraception for the duration of therapy. For example, the retinoid isotretinoin has a REMS program called iPledge that requires many of these example measures I just listed and is under a restricted distribution plan with the goal of preventing fetal exposure to this agent. So these are just 2 examples of measures in place to promote the safe and appropriate use of medications with teratogenic risk that I wanted to introduce that are very relevant to the example teratogenic retinoid that's included in the IQ case this week. So keep this in mind as we move forward, because as we start to introduce different medications in each block, I will try to point out which ones have sort of this pregnancy risk that we need to be aware of, as well as these REMS programs.